Okay, Athens, help is on the way to clear the screen, or rather get it to where that you guys can see the content.
Break it more. Break it more.
Okay, so Augusta and Albany can hear me. What about Savannah?
We can hear you.
Okay, thank you so much. Okay, so I'm going to kind of talk about renal cell carcinoma a little bit and go through most of that in today's lecture. And then at the end, I also have some slides on bladder cancer as well. But most of the content is going to be on renal cell carcinoma. And this is a very interesting cancer because this is one of those cancers that was considered hard to treat. But about 10 years ago, we started to have an explosion of targeted therapy. And these targeted therapies really allowed us to get a handle on how to treat this disease. And what I think is really unique about it is that the approach to renal cell carcinoma starts out with surgery. And if we can do surgery, great, that's ideal. When we start to think about chemotherapy for follow-up, and especially for those that have advanced metastatic disease, what we typically try to do is a sequential treatment with different drugs, meaning you give a drug for first line, and we allow that to work for as long as it's able to. But because it's targeted therapy, you're going after a specific molecular event in the cell. And when you do that, the cell being a biological system, will then develop mechanisms of chemoresistance. And so it's at that point that we have to switch over to second-line drugs and think about some sequences and approaches that we want to use. And in sequences, now we have a lot of options. We have options for first line, and we have options for second line. And we don't have a lot of information. I mean, we're starting to get information from clinical trials as what's the best drug, how to use it, how to apply to, those drugs to the situation. So what you're going to notice in today's lecture is that I'm going to give you the information about the sequences, and then I'm going to talk to you about the drugs. And it may look a little bit messy in terms of why aren't there like very discrete types of drugs for first line, second line, and so forth. And again, clinical trials are going to work all of that out eventually. Okay, so Athens, can you see the slides at this point?
Yes, ma'am.
Okay, great. All right, so I'm going to go to the first slide. And so the session ID is 657766. And the question is, what is the median age at diagnosis? And the options are 45 years, 55, 65, or 75. So what is the median age of diagnosis? And for that, I'm talking about renal cell carcinoma. Is it 45, 55, 65, or 75?
We're having some technical difficulties in Augusta right now.
Okay, I'll wait a few more seconds. Thank you for letting me know.
So where is she then? Is she in Albany again?
Okay, seeing the responses come in, is it okay if I advance the slides now, Augusta?
Yes.
Okay, thank you. All right, so the average age is, excellent, 65 years is the average age, median age of diagnosis for renal cell carcinoma. So these are the drugs we're going to talk about in today's lecture. And again, the treatment landscape for metastatic renal cell carcinoma has really changed. I mean, historically, we were using immunotherapy, but now we have so many different targeted approaches for treating this disease. So over the past 6 decades, the rate of renal cell carcinoma has risen by what each year? So over the past 6 decades, the rate of renal cell carcinoma has risen by what percent each year? Okay, so let's see how the class responded to this answer. So over the past 6 decades, the rate of renal cell carcinoma has risen by, the correct answer is 2% each year, 2% each year. But the point of it is that this is on the rise, and there are a number of cancers on the rise, but this is included in that. So let's talk about some facts for renal cell carcinoma. So in 2016, we had approximately estimated as 62,700 new cases of renal cell carcinoma. Now, 40,000 of those are going to be in men, so this is clearly a cancer where you have a stronger risk factor in correlation if you're male rather than female. Now, out of those, only 14,240 are estimated to have mortality from this each year, which is not an ideal statistic. But what we're going to talk about in this lecture is that we do have a lot of therapeutic options to keep this number low. We do know that there are some risk factors for developing renal cell carcinoma, and that includes cigarette smoke, obesity, and the fill in the blank that I have on this slide is misusing pain medications. Even misusing over-the-counter pain medications over a long period of time. Workplace or living conditions where you have exposure to asbestos or cadmium, and then genetic conditions whereby you have inherited a germline situation where you have the von Hippel-Lindau syndrome. And so those are risk factors for renal cell carcinoma. There are a number of treatment strategies for this disease, surgery being the gold standard of care to remove all or part of the diseased kidney. So this comes in the form of partial, simple, or radical nephrectomy. Partial being the procedure to remove the tumor within the kidney and any tissue around it. Simple being just to remove the kidney. And radical, the surgery to remove the kidney, the adrenal gland, and all of the surrounding tissues. Now, if a patient is going to have partial nephrectomy, only a major cancer center is going to perform this surgery because when you do this surgery, you have to clamp the major artery going into the kidney. And once you do that, you only have about 30 minutes before tissue necrosis sets in. So again, this is a highly trained and specific and specialized type of surgery that has to go on. Because when the blood pumps, about 25% of it is being filtered through the kidneys. So there is this window that the surgery has to be performed. And so this is why a simple nephrectomy can be performed as a procedure in other other hospitals and other facilities. Surgery may be followed by chemotherapy. And adjuvant chemotherapy previously had nothing to offer. Now, after surgical excision, 20 to 30% of patients with localized tumors are still going to relapse. And so we still have issues with relapse situations, even though surgery is ideal. Now, we know that a person can live with part of one working kidney, but if both kidneys are to be removed because of this disease, then the person is going to need dialysis or possibly a kidney transplant. Current treatment strategies can cure more than 50% of patients with stage 1 disease. Results in patients with stage 4 are very poor. And so what does this look like? So stage 1 and stage 2 disease have about a 91 to 92% 5-year survival rate. And so the point of that is just that it is incredibly high. If we can catch renal cell carcinoma at stage 1 or stage 2, there's a 91 to 92% chance that those patients will be surviving at 5 years. That is a fantastic statistic. Now at stage 3, it's pretty good as well. At stage 3, we're still at about 60% survival for 5 years. And 60% survival, that's still pretty good. It's not until stage 4 where survival drops to 11% over 5 years that this becomes a far more challenging type of disease to treat. Responses to cytotoxic chemotherapy generally were not above 15 to 90% for any regimen that has been studied. So there was no standard traditional cytotoxic chemotherapeutic regimen that existed. And here you see some of the results from clinical trials where chemo wasn't effective in renal cell carcinoma, and that's looking at gemcitabine with 5-fluorouracil or 5-fluorouracil alone or vinblastine. We just really didn't see good responses. And the rationale for this is that renal cell carcinoma is refractory to chemotherapy because both normal and renal proximal tubules and renal carcinoma cells express high levels of P-glycoprotein. This is an efflux pump. So what this efflux pump does, it mediates multi-drug resistance by just pumping out xenobiotic compounds. It doesn't really matter what the compounds are. They're xenobiotic and they're toxic, and it's just going to pump them right out. So chemotherapy is not staying at the site of action. So what we learned from this was that therapy has to be much more selective and much more targeted for the tumors in renal cell carcinoma if it is to be effective. And so the strategy was to use novel therapeutics in sequence. So we have lots of clinical trials that are ongoing against hard-to-treat cancers. And so I have some of these listed here. And renal cell carcinoma was considered, and is still largely considered, a hard-to-treat cancer, similar to pancreatic cancer or late-stage advanced metastatic melanoma, and also refractory diseases. So these therapeutics are controlling the progression of advanced renal cell carcinoma, and they developed into this new idea of chronic disease management in oncology practice. And so the image that I have here illustrates this grotesque tree growing out of control and growing outside of its boundaries. And the idea behind renal cell carcinoma is we try to surgically cut out as much as we can, and then we try to treat where we're just sort of trimming the branches and just doing what we can do to keep the cancer refined and restricted into a space whereby it won't cost the life of the patient. And the theory behind that is that a patient might not be so concerned with having a disease if it's going to have absolutely no correlation with their survival, and that they could live with this disease if we can just continue to hold it at bay. And they try to do that with first line and second line and subsequent targeted therapies for renal cell carcinoma. But this is still largely in practice and in clinical trials to see what is most effective for this condition. So therapeutics fall into several categories. We have immunotherapy, and then we have targeted therapies. And so we'll go through these targeted therapies. Immunotherapy was the way that we used to treat renal cell carcinoma before we even had targeted therapy. So the obvious point of this is that immunotherapy is designed to enhance the body's own immune system to fight off the cancer. Since renal cell carcinoma was unresponsive to chemotherapy, what else was there that we could do? So in the 80s and 90s, we used immunotherapy. For targeted therapy, we use mTOR inhibitors, which mTOR is the mammalian target of rapamycin, and I don't expect you guys to remember or sort of appreciate that, but I will show you some slides where you see that it's intracellular protein that's involved in signaling. So we have targeted inhibitors against that. We also use angiogenesis inhibitors because this is a hypervascularized type of cancer. And then we also use targeted inhibitors like the tyrosine kinase inhibitors. And these are in large part inhibitors of the vascular endothelial growth factor, so VEGF. And we have a whole series of those. We have pazopanib, axitinib, sunitinib, and sorafenib. And we've talked about sorafenib previously in the context of hepatocellular carcinoma. So with immunotherapy, in what other disease that we studied did we rely on the use of immunotherapy? So interferon, interleukin, Opdivo, ipilimumab, what other disease do we rely on the use of immunotherapy, at least historically? I mean, we have some targeted inhibitors as well.
I think it might be melanoma. Yeah, you're right.
The session ID was 657766. So the session ID is 657766. Okay, so let's see what the response was. Excellent. Melanoma. So melanoma in large part relies on immunotherapy. And again, historically, this is because melanoma and renal cell carcinoma just did not respond to cytotoxic chemotherapy. And yet, as it turns out, these diseases are really paving the way for the next generation in therapeutics and how we're looking to treat cancers in the future. I include this as a visualization so that you can see the location of where these targeted inhibitors are working. I like visuals. And so that's why I included this. And the VEGF receptor is at the top right, and you can see pazopanib, axitinib, sunitinib, and sorafenib inhibiting the VEGF receptor. You also see bevacizumab inhibiting VEGF itself. And then inside the cell, intracellularly, past the bilipid plasma membrane cell surface layer, you see temsirolimus and everolimus. And these are inhibitors for mTOR. And again, that means mammalian target of rapamycin, which you don't have to remember. Just from a teaching perspective, I think it's important that I tell you that that actually stands for something with meaning. And again, we use these inhibitors for VEGF because metastatic renal cell carcinomas are hypervascularized tumors, so they have increased levels of VEGF. And so we're going to spend a little bit of time on this slide because this slide lays out the long-term strategy for disease management and the currently recommended sequence of drugs. So I have here listed 1, 2, and 3. 1 and 2 are your first line therapeutics. And so that means sunitinib, bevacizumab with interferon, temsirolimus, or pazopanib. These are all first line indicated therapeutics for favorable or intermediate risk groups. I'll talk about that in a minute. And so that means for first line, you have a choice of 4 different regimens. What is most often used is sunitinib. So that's why I also have on this slide first choice of therapy. Sunitinib is by far the most widely used first-line agent for renal cell carcinoma, in large part because it was launched in 2006. So it arrived on the scene first in class, first-line treatment. And then in 2009, it had global sales of $1 billion. So it's really a widely used drug. What also happens when you're the first is that people start getting used to your drug, your side effects, and they get comfortable with that. And so it's sort of a trend that catches on. However, pazopanib has really given sunitinib a run. And so I'm going to show you subsequent slides where now we're really questioning whether or not sunitinib is the best choice. Sunitinib also has this really weird dosing schedule, which we'll talk about in a second. Now, if you are in a poor risk group, this is why on the slide for number 2 and number 3, I have the mTOR inhibitors shaded in a sort of a browny orange, or I guess on the slide it actually looks more like a brown color. And so that's temsirolimus and everolimus. These are shaded in brown because they're mTOR inhibitors. And if patients fall into a poor risk group, mTOR inhibitors show the most benefit. So let me repeat that. If patients fall into what would be classified as a poor risk group, the mTOR inhibitors will show the most benefit. Now, how would one know if they're in a poor risk group? So in the table that I have on here, the notes for temsirolimus in a poor risk group are that it's according to MSK-CC risk criteria. MSK-CC stands for Memorial Sloan Kettering Cancer Center. So they have this sort of risk criteria outlined. And it is not required that you guys know what that criteria means. If it were, I would have written it out on the slide. But they basically have these unfavorable prognostic indicators. And if a patient has more than 3 of these 6 unfavorable prognostic indicators, then they fall into a poor risk group. And so those indicators, again, which you don't need to know for testing purposes, are things like a Kartovsky's performance, hemoglobin levels, calcium levels, whether or not the patient has metastatic disease, serum lactate dehydrogenase levels. So there are a number of these things. And if they have those unfavorable prognostic indicators, then they fall into a poor risk group. And then their first line is going to be an mTOR inhibitor, and that first line mTOR inhibitor is going to be temsirolimus. Otherwise, if they're in a favorable or intermediate group, first line is going to probably be sunitinib, although bevacizumab with interferon is okay, and pazopanib is okay as well. Now, what we know is that these patients are likely going to develop drug resistance to these first-line agents. When they develop drug resistance, now we come in with second-line therapies. And so patients whose metastatic renal cell carcinoma progressed during initial VEGF tyrosine kinase inhibitor therapy, they may continue treatment with a different VEGF tyrosine kinase inhibitor, or they may switch treatment to mammalian target, a rapamycin inhibitor, with a different mechanism of action. It really depends on the facility, the treating physician, the oncology group. They try to personalize these, and sometimes they'll do that with toxicities and efficacy, whether or not the patient experienced a lot of toxicities when receiving first line, the aggressiveness of the disease, the performance status, and like I said, the clinician's familiarity with the agent and whether or not the clinician knows and is comfortable with managing the side effects of that particular agent. And for patients who display intrinsic resistance to first-line VEGF tyrosine kinase inhibitor therapy, studies have demonstrated they generally are going to have poor responses to second line, regardless of what decision you make. So if they didn't respond well to first line, you can choose sorafenib, axitinib, or everolimus, but they're probably not going to respond well. And so this is where I said it's kind of messy in terms of what do you do for second line. But these are your options in terms of first line and second line therapy. And so what I have on this slide is the comparison between these drugs, axitinib, pazopanib, sorafenib, which you've seen before, and now sunitinib. So all of these inhibit VEGF receptors 2 and 3, and then most of them inhibit the PDGF receptor, platelet-derived growth factor receptor, but then some of them inhibit FGFR 1 and 3, some do c-KIT, some don't. So there is some slight variability when they made these targeted therapeutics as to what exactly they bind to and what is their mechanism of action. The indications differ slightly, although again, we're talking about these in the context of advanced renal cell carcinoma. So for example, pazopanib is also approved in soft tissue sarcoma, and sorafenib is approved, of course, in hepatocellular carcinoma. These are oral. Some of them have special considerations. For example, again, with pazopanib, the first consideration I have here is to monitor liver function. And the black box warning for pazopanib is literally hepatotoxicity. So with pazopanib, the black box warning is severe and fatal hepatotoxicity, which has been observed in clinical trials. So it's really important to monitor hepatic function and interrupt, reduce, or discontinue the dosage as recommended. So again, they're a little different. What I have on the next slide is some abbreviations. So I know I've been saying a lot of things like VEGF 1, 2, and 3, PDGFR, and here are the abbreviations for what exactly do those things mean. We're talking about the vascular endothelial growth factor, platelet-derived growth factor, and so forth. And so some of these I have on this slide just to make everything kind of fit on this slide, and then I've defined them here.
Dr. Murray?
Yes?
On the strategy slide, the one before the big table, what does that arrow mean?
That arrow means that if pazopanib, because it's on pazopanib, this is a really good question. So if you haven't used pazopanib as a first-line treatment, pazopanib could be used as a second-line therapy. So you have flexibility with pazopanib, whether you want to use it or first line, and if you skip over it in first line, it can be put into second-line treatment for the disease. That's a good question. And so all of this slide just shows you the reason why sunitinib overtook sorafenib in 2006 when it came on the market. And what you want to look at is the progression-free survival. So the progression-free survival for renal cell carcinoma for sorafenib was 5.5 months. When sunitinib came to market, the clinical trials showed that there was 11 months. So this is the obvious reason. Why did sunitinib overtake it? Again, because at the time there was not much else on the market. Sunitinib was approved in January 2006, and it was the first oncology product to gain FDA approval for 2 indications simultaneously, for GIST, gastrointestinal stromal tumor, and for renal cell carcinoma. And so this is just another visualization to look at what sunitinib is inhibiting, all of the various receptors. So a lot of times they try to make very specific kinase inhibitors, but structurally, perhaps our technology that we have today isn't capable of making them as specific as they want. So this hits a lot of different targets. And what you see on the left is before and after treatment. So before treatment with sunitinib, you see this tumor that is in the lungs, and then after treatment, you see tumor shrinkage. Now, tumor shrinkage, in order to receive FDA approval for a drug, you have to have more than 33% change in tumor size, qualifying for a partial response according to the criteria. And so sunitinib met this criteria. So I just didn't want to confuse the situation and make it seem like this drug is able to completely eliminate all of the cancer. That's not necessarily the case. But it is effective, and it did receive approval. And so that leads to my next question, which should be pretty obvious. What is the most common site of metastasis? So what is that organ where you see treatment of sunitinib and the shrinkage before and after? What is the most common site of metastasis for renal cell carcinoma? So when we talk about metastasis, we know that they have patterns where we can predict where the cancer is going to go and reside and where it's going to appear next. And so for renal cell carcinoma, what is that site? Okay, so let's see how the class responded. That is correct. That is the lungs. So the lungs is the most common site of metastasis for renal cell carcinoma.
30% shows liver.
And here is a comparison between sunitinib and pazopanib. And again, recall that sunitinib came first. It came years before pazopanib was around. But when we go head to head, when we look at the response rate between these two drugs, we see that pazopanib has a greater response rate than sunitinib, whether it was the IRC assessed or investigator assessed. These correlate pretty well. What we also see is that during the first 6 months of treatment, the health-related quality of life scores in the pazopanib group are better than those in the sunitinib group when we ask them about quality of life. Pazopanib reports better quality of life. And so going along with that, here is just a generalized list of all the different adverse events that you can have with pazopanib and sunitinib. But with fatigue, hand-foot syndrome, dysgeusia, rash, which is lack of taste, rash, constipation, dyspepsia, we see a reduced rate with pazopanib almost for every single thing versus sunitinib. So this again gets to quality of life. But what you see in the top right-hand corner of this slide is the probability of progression-free survival, where these lines they look like they're almost on top of each other. So there's no statistical significant difference for progression-free survival, nor overall survival in clinical trials that have followed up. So really the difference that we see here is the quality of life comparisons, in addition to this sort of craziness that we have with sunitinib. So sunitinib has this schedule where patients take 4 weeks, they're on it, and then 2 weeks, they're off of it. So we call this the 4-2 schedule for sunitinib. And again, that means sunitinib, you have 4 weeks on and 2 weeks off. And so the 2 weeks off, you have a drug holiday where the patients are not receiving sunitinib. Now, the red lines in the graphs that you're looking at, that's sunitinib, and that is the sort of quality of life measurements when we look at things like anemia and thrombocytopenia and neutropenia. Sunitinib, you see these spikes when the patients are on the drugs. And then once they stop the drug, then you see these spikes come down. And then you put them back on the drug, and there are spikes. So there are, these commonly adverse events that are reported more frequently with sunitinib than pazopanib. Patients in sunitinib groups, they have a higher incidence of grade 3 or grade 4 adverse events. And again, there's sort of this weird scheduling. And so why is there this 4-2 schedule for sunitinib? The reason is because during the clinical trials, what they saw in animals was that rats had bone marrow depletion that were on sunitinib, and rats that took sunitinib also had adrenal microhemorrhage. And so health authorities were really concerned with this, and so they requested this intermittent dosing schedule with this drug before it received FDA approval. And so that's why there is this 4-2 schedule. Now, why it's likely that pazopanib might take over as first line is because you see these just very straight blue lines, and so that's pazopanib. So when we look at things like neutrophil levels, so the bottom right graph, the neutrophil levels stay higher with pazopanib, which, of course, for cancer patients, that's a really big deal to not have them at risk for infection. Okay, and so these are second-line inhibitors. So the slide that we're looking at now, the question really is, who's on top for second line? No longer first line, that's going to be between pazopanib and sunitinib to battle it out. So here we're looking at axitinib and sorafenib. And so when we look at the graph on the top right, we see that there is a statistical significance for axitinib for progression-free survival over sorafenib. However, we see that there are a higher percent of patients that have adverse events that are on axitinib. And that dose reductions of sorafenib, that's going to apply to most patients that are on sorafenib. They're going to need a dose reduction at some point, but only about a third of all patients with axitinib. And so if this all sounds confusing to you, then that just means you're paying attention. Because it's really hard to decide which drug to go with. Do you go with the drug that has a little bit more statistical significance for progression-free survival? We're not talking about overall survival. But you do that knowing that there's going to be a higher percent chance that you have side effects, but that you're not going to need dose reductions. Or do you go with the drug where you're probably going to need a dose reduction, but you're going to have less adverse events? So it's still really up in the air as to which one of these is better, but they're both options for second-line treatment. Okay, so now let's move on to the mTOR inhibitors. So the first slide that I have here talks about rapamycin, and the other name for this is sirolimus. This is an oral drug given to prevent donor graft rejection, so like bone marrow transplants. It's also an immunosuppressant, a kinase inhibitor, and a cell proliferation inhibitor. So it has these anti-neoplastic activities, but it also has antifungal activities. And the name of rapamycin comes from Rapa Nui, so that's the Polynesian name for Easter Island. Scientists first isolated the compound from a bacteria that was located in the island's soil. The bacteria apparently secreted rapamycin to fend off other bacterial and fungal rivals. And so that's how this drug came to be. Now, this drug isn't, of course, used in cancer, but it is sort of the grandfather of the mTOR inhibitors that we do use in cancer. And so that's where we got the mammalian target of rapamycin. Rapamycin was working, and then they had to go back and figure out, well, how is it working, and how is it inhibiting cell proliferation? And then they go back and say they sort of named the protein after this. Now, when we think of the mTOR inhibitors in cancer, the problem that we have is that non-infectious pneumonitis is a class effect of these rapamycin analogs. And so with non-infectious pneumonitis being a class effect, therapy has to be interrupted if this should occur, pending further diagnostic evaluations. And so patients have to be closely monitored for new or progressive pulmonary symptoms like cough, dyspnea, and fever. And so this is just one of those on-target effects of the drug. And this is just a visualization to give you an idea of when we're talking about mTOR inhibitors, where are they acting and what effect are they having. So again, I like visuals, and so here I'm just trying to point out where everolimus and temsirolimus work, and that's through the inhibition of mTOR, which is an intracellular signaling protein in the cell that inhibits proliferation, cell survival, cell cycle, and so forth. And so the pharmacology of rapamycin or sirolimus needed to be improved. The analogs, temsiros and everolimus, had more stability. Rapamycin lacked stability and aqueous solubility, so it was really unsuitable for further development in this indication. And so that's where we got temsirolimus and everolimus. Now, temsirolimus has to be given intravenous, whereas everolimus is an oral drug. And here's just the comparison between these agents. So what their indications are, whether they're IV or oral, and then some of the special indications. And of course, toxicities. Temsirolimus got FDA approval in 2007 for advanced renal cell carcinoma. It is given intravenously over a 30 to 60 minute infusion once a week. And before the infusion is given, intravenous antihistamine is recommended to help reduce the chances of an allergic reaction. And so what you're seeing on these graphs on the bottom of the slide, this shows the progression-free survival on the left and the overall survival on the right in some of the clinical trials where they were trying to determine the best dosing for temsirolimus. So they tried doses of 25 milligrams, 75 milligrams, and 250 milligrams. And when you look at the progression-free survival, the 25 milligram and the 75 milligram were essentially very similar, 6.3 months, 6.7 months. And then when you look at the overall survival, there was 13.8 months, 11 months, and then 17.5 months. And so they chose the lowest dose, 25 milligrams. And I just point this out to kind of generate your thinking in terms of the huge difference between cytotoxic chemotherapy versus a targeted agent. So a targeted agent, the dosing is based on how much does the patient need to inhibit that target. And when you achieve that level, that's it, you stop. So you might be choosing the lowest dosage that was used during a clinical trial. Versus chemotherapy, we're always looking at what is the maximum tolerated dose. So with cytotoxic chemo, it's how much can we give the patient before there's a dose-limiting toxicity that's going to kill the patient. And that's kind of how they set the dosage for cytotoxic chemo. So it's a completely different way of thinking about dosing between a targeted inhibitor and cytotoxic chemotherapy. So moving on, temsirolimus. Yeah?
Can you go back to the chart? There was a missing blank. Is it just mTOR for that blank?
Right. You mean for the rapamycin?
Yes, ma'am.
Yeah. Yes, that's a good question. Okay, so let me clarify. So that missing blank, it's mTOR, but you don't need to know information about rapamycin. I have only included it just as a comparator. You guys are probably already familiar with this drug, but I've included it as a comparator, and I've also included it just so you know, where did the idea of temsirolimus and everolimus, where was the idea generated from? And where did these drugs stem from? But yes, it's mTOR. Okay, so how did temsirolimus compare to previous first-line therapy? And with the median overall survival by itself, it was 10.9 months, which was better than what we saw for the other drugs. And so that's why it overtook for first-line therapy. And again, it was better to use for those of the poor risk category as defined by the Memorial Sloan Kettering Cancer Center criteria. Okay, we're going to skip through that one. That's not necessary. Apologize for that. I should have taken that one out. Okay, so now we're going to talk about bladder cancer for the last few minutes of class. For bladder cancer, we have 76,960 new cases in 2016. Again, most of these are men. Men are 3 times more likely than women to have bladder cancer. It's the 4th most common diagnosis in men, and it's much more common in Caucasians than other races. So how might someone develop invasive cancers? What are the risk factors for bladder cancer? We see smoking, industrial chemicals in workplaces, chronic bladder irritation and infections like frequent kidney stones, bladder stones, arsenic in drinking water, not drinking enough fluids. So people who drink a lot of fluids each day actually have a lower rate of bladder cancer. This is thought to be because they're emptying their bladders more often, and by doing this, they keep those chemicals from lingering in the bladder and from lingering in the body. So it's interesting to see so many people nowadays carrying around water bottles, and whether or not this is going to really drop some of the risk factors for bladder cancer, decades into the future. And also long-term cyclophosphamide. So cyclophosphamide, ifosfamide, these cause, a lot of bladder damage. They increase the risk of bladder cancer, and so that's why we do a lot of hydration and we do a lot of mesna and tell those patients to drink plenty of fluids to help protect the bladder from irritation to decrease the risk of bladder cancer. The most common forms of disease management begin with the techniques to remove or destroy tumors. So this is in the form of transurethral resection. This is a surgical technique where a cystoscope is inserted into the bladder through the urethra, and then the tumor is removed through the cystoscope. We also have fulgration. So fulgration means the full destruction of tissue, usually malignant tumors, by means of high-frequency electrical current that is applied by an electrode. And here we're getting a look at what that is. So this is the surgical removal of the bladder lesions by inserting this endoscope through the urethra. Now, if they want to remove the entire part of the bladder, they would only do that if it was invasive cancer. So if there's really invasive cancer, yes, they're going to go in and they're going to remove all or part of the bladder. But this is a very serious surgery if they have to do that, and that's only for the invasive bladder cancer. And if they do that in men, it's very similar to a prostatectomy because they remove the prostate gland, seminal vesicles, and impotence is a risk factor, just like radical prostatectomy. So that's only in the case of really invasive bladder cancer. So standard treatment options for early stage or stage 1 is transurethral resection with fulgration. And this is where they're burning off the small tumors. It's uncomfortable, but again, you have a really high survival rate for something like this. Also transurethral resection with fulgration, followed by intravesical BCG, Bacillus calmette-guerin, or transurethral resection with fulgration, followed by intravesical chemotherapy. So the types of drugs that are going to be listed on the next slide. And this is where the treatment is put directly into the bladder through a catheter. So it's not given orally, it's not injected into the vein. And it's instilled during like 5 minutes, and then it's put in there for a couple of hours, and then it's flushed out. And so the chemotherapy I have listed on this slide is a blank, I believe, on your slides that you need to fill in. And that is chemotherapy, BCG, mitomycin, thiotepa, doxorubicin, or gemcitabine. So this intravesical chemotherapy is done either multiple or recurrent tumors as a prophylactic measure in high-risk patients. And again, it is instilled through a catheter. That lasts about 5 minutes, and then it's left in the bladder for a couple of hours before it's removed. And this prevents having that systemic chemotherapy and all of the adverse effects that would occur through other organs being affected as well. So these are the major advantages of doing it this way. You're avoiding many of the unwanted side effects. And BCG you're probably familiar with previously in the curriculum. This is one of the most effective medications for bladder cancer given once a week for 6 weeks. The goal is to stimulate the patient's immune system to fight off the cancer. And immune cells are attracted to the bladder and they're activated by this. So it's immunotherapy in bladder cancer. Now, if it's advanced bladder cancer, then you have options of using 2 of these 3 drugs in combination. And so that is seen here. Cisplatin or carboplatin, the taxanes, that means paclitaxel or docetaxel, gemcitabine or capecitabine. And typically the first line standard choice regimen is cisplatin and gemcitabine. Okay, and this is my last slide. Thank you so much for your attention. So which of the following is a risk factor for bladder cancer? Low fluid consumption, workplace exposures, chronic kidney stones or bladder infections, or all of the above. Thank you so much for your attention, and please email me if you have questions.
What's the answer?
It's all of the above.
I mean, I'm assuming it is, but yeah. But like, are we gonna confirm that?
Not important.